Hey.
Hi.
Oh, cool.
My lesson here is okay. I'd like to talk with you.
Yes.
More than one conversation.
Sure, absolutely.
I'm just like,
start
One
shortly.
thing to just
herself. Right. Okay.
The multi.
Somebody said.
Nope.
Susie, her.
Are you having lunch too?
Yeah. Yeah, we got enough for everybody.
Yeah, they're just frozen my cheese.
Oh,
There's like a Cobb salad and like a.
Reports reflecting we have PA from incarceration.
Have at it.
Nice, thank you.
Hey everybody,
And there's coffee.
we're gonna go ahead and get started. I'm sorry if you guys are having trouble hearing me, but we'll muddle through. Okay. So we do have 2 cases today, but we also have a didactic, and we're actually gonna start with the didactic and then move into the cases. So I'm gonna start with introductions, and then we're gonna let Carolyn take it away. So Jenna, do you care to start with introductions?
I was trying to find the tab on my browser to get you pulled back up. My name's Jenna. I'm a PA for community care of West Virginia. I work in Rock Cave, which is a really rural town southwest of Buchanan.
Perfect, thank you. All right, Kristen, do you want to introduce yourself?
Hi, I'm Kristen. I'm a third-year medical student. I'm currently participating in a rural rotation out in Fayette County. I've been working with the health department out there a little bit, and so I wanted to learn more about how to take care of people with hepatitis C.
Perfect.
Thanks for having me today.
Yeah, thank you for joining. All right, Dr. Rexroad.
Hi, I'm Carmen Rexroad, family physician in Franklin and Pendleton County.
Perfect, thank you. And Dr. Peters?
Hey, I'm Greg Peters. I'm a family medicine doc in Buchanan. I also work with Community Care of West Virginia.
Great, thank you so much. All right, and Jennifer Boyd?
Hi, Jennifer Boyd. I'm a physician assistant at New River Health Center in Fayette County. So welcome to Fayette County, Kristen. And I'm about to go get my lunch, but I'll be right back.
I understand. All right, let's see. Jonathan, Dr. Biggers?
Hello, John Biggers. I'm a family practice physician out in King William, Virginia, rural community health center, and just learning more about Hep C.
Excellent, thank you.
I also have a third-year medical student with me from VCU.
Right, perfect. Excellent. Do they want to introduce themselves?
There he is. Nice meeting. Nice meeting.
Great, thank you.
Stephen Ellis.
Perfect. All right, Tracy Thornsbury.
Hi, I'm Tracy Thornsbury. I'm a nurse practitioner of Williamson Health and Wellness, and just kind of sitting in to listen. This is our second echo. Happy to be here.
Awesome, thank you so much. All right, Dr. Pollywall.
Hi. This is Dr. Himanshu Paliwal from Fairmont, MVA Fairmont Clinic. I'm a family physician. Thank you.
Great, thank you. All right, Susan?
Hi, I'm Sumi Kenrick, and I'm just getting rolling with a Hep C clinic at Milan Pushkar Health Right in Morgantown.
Great, thank you for joining. All right, and then Rachel?
Hi, I'm Rachel. I'm one of the pharmacists in the specialty pharmacy here at WU Medicine.
Perfect, thank you for joining. All right, so guys, we have a full room. I'm gonna try to let you guys all see, but we will see how that goes. All right, go for it.
Wow.
Jay Mason, Assistant Director for Project ECHO.
I'm Jean Colonel. I'm an advanced practice nurse who work in hepatology.
I'm Justina. I'm a second year internal medicine resident.
Hi, Susanna Massardis, Executive Director for the Community Liver Alliance.
I'm Kaylee Berner, nurse practitioner with infectious diseases. And I'm Carolyn Kidd, clinical nurse educator with the Mid-Atlantic AIDS Education Training Center.
I'm Caitlin Ettinger.
Hi, I'm Mitra Motasham, and I am a Project ECHO coordinator here.
I'm Allison Cost here with the Liver Alliance. I'm Kelly Martin. I'm a nurse practitioner with hepatology and the Community Liver Alliance.
All right,
Awesome.
we got through it all. Yay. Dr. Tierney, do you want to introduce yourself?
Sure. Dr. Tierney with Cabin Creek Health Systems in Kanawha County, West Virginia.
Excellent. All right, guys. So I'm going to let Carolyn start with her didactic, and then Jenna is going to give 2 cases for us at the end. So I'm going to let Carolyn take it away. You want to click, or do you want me to click?
I can click.
You can click. Let me pull it up for you real quick.
Okay.
Oh, perfect. Thank you. Take it away.
Hey, everybody. It's so nice to see so many faces this morning, both online and around the table. Before I get started, I want to let y'all know something, and I just found this out today. So Health Right here in Morgantown, the Light Project, they are starting a harm reduction clinic in Elkins, and it begins Tuesday, November 19th, and it's going to go the 3rd Tuesday of every month. Yay!
Wow.
Sweet!
That's great.
That's right. And the only reason I knew about that is because I was looking at Facebook while I was at work.
We're not recording yet. Are we recording?
But I was looking at Facebook for a good reason, but I'm not telling. So anyway, I thought this is awesome. You know, it's going to be right in some of y'all's backyard, and just thought you might need to know about it. At the beginning, they're going to be doing, they're giving out kits, exchanging syringes, and doing some education. I'm not sure when or if they'll be doing any HIV testing or hepatitis C, but that'll come down the road. At least it's a beginning in that area, which I think is so wonderful. So yay to Health Right and the Light Project here in Morgantown. And then when I'm finished, I'm going to get up and leave. Because I have a couple things I have to do this afternoon. But anyway, so I'm talking about an adolescent sexual risk and doing a risk assessment on these youngsters because somebody in your group asked to have this done. And I think that, you know, it's pretty much common sense for everybody, but adolescents are a different beast, as we all know. Thank goodness mine are kind of out of that, and they're young adults now. It was a little painful at times. But I do still talk to them about their sexual risk, even though they're 30 and 36. Yeah, see, I can do that because I'm their mother. Since they were 3. I started talking to them about their sexual health when they were 3 years old. Now it's on to the grandchildren. All right, how do I
just click on the slide?
Click on what?
Yep, that right there.
So there's a disclosure. You can read that, and I do not have any relationships to disclose. So do you think that our kids are having sex? I do. Do you think they're starting pretty young? About 10? Yeah? Ooh, that's kind of icky, isn't it?
Yes.
When are you going to start talking to your little one?
Never. A lot of kisses girlfriend that he has right now.
Oh. So this information is from the Youth Risk Behavior Survey from 2017, and this is done every 2 years. So this is a little bit old at this time, but regarding high school students starting in 9th grade to 12th grade, almost half have had sexual intercourse. About 10% had more than 4 sexual partners. Why is that problematic? Anybody know? Because the more partners you have, the higher risk that you have to get an STD or STI, including HIV. So in the previous 12 months, 30% of those had sex and almost half did not use a condom. A lot of that's related to availability and then the stigma that might still be attached to a kid going to the drugstore to get a condom. Some did not use any method whatsoever to prevent pregnancy. Some drank and used drugs before their last sex act, which really puts them at increased risk because you know what happens when we're drinking and drugging, we really lose our inhibitions. And 7% had been forced to have sex. And a very small amount have ever been tested for HIV. But this is the group that's at really high risk for HIV. So what is the biologic risk regarding them being at increased risk for STDs? Lower circumcision rates. If a male is circumcised, that's actually one of the HIV prevention models that's used on a global level is adult male circumcision related to the Langerhans cells. They're in the foreskins of the penis. These cells have an affinity for attracting HIV. They actually have one HIV receptor site. So if you remove that foreskin, then you have decreased quite significantly the risk for acquiring HIV. A lack of immunity and having concurrent STIs. You guys have frequent flyers among your adolescent and young adult population with STDs? I'm sure you probably do. So with any concurrent STD, especially those that cause an inflammatory reaction or any kind of lesion, that will greatly increase the risk not only for acquisition but transmission of this virus to sexual partners. And then, of course, their cognitive development. Their brains continue to develop into their early 20s, so they really don't understand consequences no matter how much we talk, whether it's a parent talking to a kid or whether it's their provider talking. And then other factors that impact development and maturation, like trauma. And I think this is a good place to put in the ACEs, the Adverse Childhood Experiences piece, because we know that the higher your score on that ACEs survey, the more likely you are to develop substance use issues, et cetera, et cetera. And if you guys have anything to say, just jump right in for questions. So the ST rates among adolescents, and this was at the end of 2017, increased chlamydia and gonorrhea and also syphilis. As a matter of fact, we're having a syphilis outbreak here in Morgantown among MSMs, men who have sex with men. Chlamydia, again, very high, gonorrhea. The reasons for the increase, of course, increased incidence, but it could be increased testing as well, and the screening among young men, and then extragenital screening, which means you screen every body orifice for STDs, the anus, the mouth, the throat, and what? Using different swabs. Using different swabs. You're right, Kelly. I'm so glad I have her here because She helped me out with this stuff. She's an actual provider and I'm not. I'm an educator. So just a little schematic of HIV among youth in the United States. They are currently 1 in 5 of all new HIV diagnoses, especially those African Americans, males that live below the Mason-Dixon line, and that does include West Virginia. Among male youth, 93% were related to MSM contact, men who have sex with men, which is kind of sad, actually. So the risk among sexual and gender minority youth compared to cisgender or heterosexual, gender minority youth are more likely to have had sex before they were 13 years old, more than 4 partners, using alcohol and drugs, less likely to use condoms, and more likely to have not used any prevention pregnancy method. Do you guys know what chemsex is? Have you heard about it? Chemsex, C-H-E-M, sex. And this is most.
Oh, I'm sorry. Go ahead.
No, you go ahead.
Is that like chemically induced, like we're like on drugs? I mean, essentially, where they
increase sexual pleasure. Yeah. So we see it mostly among MSMs, especially youth and young adults, MSMs. So chemsex. And then among transgender, do you all as a group have many transgender adolescents? Anybody that maybe has never even begun the process of transitioning, or those that have maybe just said to you, this is who I am, this is what I want to be?
I have a number of middle school students who we do a screening questionnaire annually that asks about sexual activity and gender identity, and I don't know the number. It's, I think, less than 10%, but more than 5%, somewhere in there, who identify as either gay or, it asks gay, lesbian, or bisexual. Oh, well, so that's sexuality, transgender. There's someplace on there where it asks about
transgender
identity. And I have a number of people in the middle school, not so much in high school.
Huh, that's interesting, actually. And I'm glad that they feel safe enough to actually fill that out on that questionnaire that you have. So
yeah, we have a pretty cool system that's been in place for a while, and they do. And I think a lot of the answers we get are truthful, especially in those younger kids. The older ones, tend to be a little more guarded. But sometimes I question. And this could be a topic for later, but sometimes I question some of the younger kids' understanding of what they're answering when they talk about sexuality, not so much about gender identity, but sexuality. I had one 12-year-old who hadn't been sexually active say that she thought she was bisexual because her girlfriend listens to her more. And I thought, well, that would probably make a lot of us bisexual. And so it's an intimacy question, not necessarily a sexuality question for some. And that
amazing how uninformed they are, isn't it? And it's, you know, and it's good that they have us, they have you guys to kind of help them along the way too. So transgender young women, the highest rate of HIV and STDs compared to other, can be associated with commercial sex work, transactional sex, number of partners, all these things. Okay, so I'll go on. Uh-oh. So how can we assess risk? And I think the primary thing that we can do as healthcare providers is really just developing trust with these young people. Because once you've done that, you've developed trust. If they've never answered one question that you had prior, they will start answering. So that trust building is so important. And then just talking about sex normalizes it. It's an everyday behavior, something that everybody does. How can I help you be healthier about your sex life? And look at changes over time, because sexuality and sex itself is just fluid. It doesn't stay stagnant over time. It provides an opportunity for education and delivery of services, and then we can do screenings as well. And then also, I think it will help them to see, if they don't have this around them in their family, what a healthy relationship looks like, and healthy sexual behaviors. So really, this slide, it's really developing trust with these guys. So some fundamentals, oh, I really like this. Keep calm and fix your face. And that's really true, no matter who we're talking to, because you never know what you're gonna hear. So some fundamentals of doing a sexual history, just assure them that anything you say is confidential. Again, you guys know all this, non-judgmental, don't assume stuff about these youth, and be very, very specific. You also, have you heard of the 5 Ps related to sexual history taking? That's identification of partners, prevention of pregnancy, protect from STDs, what are your sexual practices, and any past history of STIs. You really want to avoid medical jargon because they don't understand it and they don't care. And then help them engage in health promoting behaviors as well. So do these things first. Talk to them about other stuff, whether it's the, what kind of music are they listening to? Do you have any questions? Oh, music, friends, what's going on in school, just, your everyday kind of stuff that they want to talk about before you start talking about sex, drugs, and rock and roll. Because that stuff's really getting into their business. And remember, you want to, I just lost my train of thought. You want to, develop trust and rapport first before the sex, drugs, and rock and roll. If you're not comfortable asking sensitive questions, you can pretend to be. I think that's easier. And young kids like it if you're direct, rather than kind of walking around sensitive subjects. And here's a really good question to ask right here. And oops, how do I go back? The arrows down. There we go. And these, I'm sure that you guys probably do already, is just letting them know that you're not singling them out, that you're asking everybody these same questions, because patients will talk to each other, and we know that. So just let them know that you're making this routine. And then how a person identifies their sexuality or their gender doesn't always tell you who they're having sex with. So that's why we don't want to make assumptions. And then you want to talk about these as well. Lots of behaviors, activities, and expressions regarding sex in and of itself. You can do comprehensive and non-stigmatizing information about sex and reproductive health, and then just talk to them even if they're not sexually active. And many of them will say, even when you ask them directly, no, I don't have sex with anybody. And they may not, but until you develop that trust, they may not say. So these are just some very basic STD screening. There's the extragenital, using a different swab at each site. And you guys can get those from the 2015 guidelines. And then regarding HIV testing among adolescents, A little over half of young adults and adolescents living with HIV are not aware of their status, and that's quite a few people. There are barriers that get in their way of getting tested. It's because they don't think that they're at risk. It's like, you know, HIV testing in older adults. Older adults don't think they're at risk either, but many of them certainly are. Access to services, and then of course that confidentiality issue for all of us, not just adolescents. So these are the HIV screening recommendations in a nutshell from the CDC. So anybody that's between the ages of 13 and 64, you want to screen once in their lifetime. And then anybody who has increased risk, you want to screen every single year. And those persons that might have increased risk would be anybody that is a commercial sex worker, anyone that sells sex for an object, a thing, or a service, a place to eat, a place to sleep. If there's been a diagnosis in the family, you also want to test the adolescent. If they request to get tested, please have the ability to either test them or refer them for testing. And then if you have clinical suspicion that indeed they might be at risk for HIV, and maybe they are showing some signs and symptoms of acute HIV infection, you want to be able to offer HIV testing to these youngsters. And you also can give PrEP to adolescents. It is approved by the FDA if they weigh more than 35 kilograms. And PrEP, as you know, does not need to be prescribed by a specialist. So if you have adolescents or young adults who you feel would benefit from PrEP, you can talk to them about it. As long as they're more than 35 kilograms, you can prescribe. There are some barriers regarding PrEP uptake in adolescents and young adults. They are the minority of PrEP prescriptions in the United States, but again, 20% or greater of new infections. There is fairly low to non-adherence among adolescents and young adults who start PrEP. Again, some of that's related to the brain development and cognitive thinking skills of adolescents. Consent laws for minors, confidentiality, disclosing same-sex behavior to their provider, or any sexual risk behaviors. And then a lack of access to comprehensive, cultural, and developmentally sensitive care. But I have a wonderful feeling that all of you on this training today at the ECHO are part of this group, or at least well on your way. So I'm done with the presentation. We actually have a pocket guide. It's a little small, developed at our central office in Pittsburgh. And this one is for case finding, primary and secondary prevention for adolescents, a clinical risk assessment and screening guide. You guys can either download a copy, or if you want, you could send me an email and I'll send each and every single one of you one of these if you want it. So if you do, there's my email. Just click and say, hey, can you send me one of those? And I'll do it. Okay? They're pretty awesome. And as a matter of fact, that's where I stole the slide information from. So I'm done.
Oh, perfect.
Any questions, you guys, or any comments?
Well, thank you so much. That was excellent.
Hey, thank you.
Excuse me, I'm sorry.
I'll give you this.
Thank you.
And we'll see you next time. Have a great weekend. Keep warm. And let me know if you want a pocket guide.
All right, guys. So if you guys have any questions for Carolyn, after this. You guys are welcome to email me and I'll make sure she gets them, or she's just given everybody her email, so you can go ahead and email her. All right, Jenna, are you good if we share your cases and get started?
Sure, yeah.
Perfect.
I've got two. With the restriction from Medicaid being lifted on the fibrosis score, I've had people like flocking into the clinic, people that I've tested that were positive, that have kind of just had maintenance and were watching and trying to reduce other risk factors and just monitoring yearly are popping in now. Even people that have seen me before and haven't disclosed they were Hep C positive and I haven't screened yet, popping in and saying, hey, so I think I can get treated now. And it's nice to know that the lift on those restrictions is kind of public, like people know, patients know about it. That's really encouraging. The first one, and to make sure I know which, okay, so this is a really a neat case as far as I'm concerned. Oh, you switched on me, Caitlin. Okay, just kidding. The first one is a female. She's 36 years old. She's an established patient of mine. I've seen her for over 3 years, and she's just been somebody we've been keeping an eye on. She's still an F0, and so as soon as we found out that the restrictions changed, I called her and I said, hey, so we can treat you now. She's got 2 little kids, and she's constantly concerned that she's real compulsive about making sure she doesn't expose them, and worry that they could have possibly been exposed at any particular point. She has a history of methamphetamine and heroin use. She's been clean for 7 or 8 years since her youngest daughter. That's how she found out she was Hep C positive. She's not sure of the exact route of transmission. She has some non-professional tattoos. She used dirty needles. She shared straws. So we don't know for sure. But she tested negative with her first pregnancy in 2010, and we weren't sure. She did use drugs during that pregnancy, so we weren't sure if she contracted it during that pregnancy, but she did test positive with the second pregnancy in 2011. I screened both of the kids, and they're both negative, so that was a big relief for her. As far as her other medical diagnoses, she has asthma. The psychiatric I'm kind of skipping because we treat it medically, but she also has bipolar disorder, which is currently unmedicated. She's just had multiple med failures and just kind of has given up. So anyway, she has asthma, which we're treating, and she's had the Hep A vaccines. She started and stopped the Hep B vaccine series in 2015. Her titers were still negative in 2018, so we redid the series and completed it. She has some, like I said, that bipolar disorder. She really fluctuates between significant depression and mania. She's a really classic case of bipolar disorder. But like I said, has failed several different medication therapies. Her socioeconomic status and her family situation right now really impedes her ability to get out to seek specialty care for that. So we're working on that together. She does not currently drink or use drugs, but she is a cigarette smoker and she's working on quitting, and we're hoping that just the improvement of knowing her Hep C has been treated is going to give her that much more motivation to completely quit smoking. Her basic labs were pretty unimpressive. No significant changes in her liver enzymes. And her HIV screening, the last time we did it, was negative. Her genotype is 1A. We did that in October. Last viral load that we did in July was 454,000. She's still at F0. And that may have been a typo. I'm pretty sure that I did her fibrosis score this year, but it was unchanged. That's all I've got for her.
Perfect. Thank you so much. All right, guys, I'm going to ask all of you guys first to give your comments, questions, insights.
Good job testing the kids. It was great. It's good to think to do that. We always forget that little people get Hep C sometimes too. It's really good. It's I thought it was pretty cool too that that she was tested way back in 2010 for hepatitis C for being pregnant. That's something that
Yeah.
you don't always see that even now. Like it's good that somebody thought to do that.
Well, I'm not 100% certain that she was like that's what she said. She said, no, I didn't have it when I was pregnant with the first baby. And then she said, they told me I was positive when I was pregnant with my daughter, the younger child. And so we didn't know if she contracted it or not during the first pregnancy even, but yeah, kind of interesting.
Jenna, did you say she's not on any medication for depression or anxiety? I know you said she's bipolar, but she's not on any medication whatsoever.
She doesn't take anything currently, and we've fluctuated back and forth. I mean, at the time of presentation right now, she's not on anything. 6 months ago, 3 months ago even, she was on Wellbutrin, and then we tried some, I think she'd been on Lamictal once before. She's had lots of different medication failures.
So she's on no medications at all?
Correct.
Not for anything else either?
Nope, she takes the occasional over-the-counter Tylenol. I muted myself because I meant to click off the screen. I think her asthma is intermittent, and I don't have her on an inhaler that I know of. Let's look.
Go for it whenever you're.
Oh, she slipped and sprained her back, and the emergency room prescribed her methocarbamol 2 weeks ago, but she's not on anything chronically.
Oh, yeah. Go ahead.
Okay. We're fighting over who's going to go first.
Right.
So this is Kaylee. Thanks so much for presenting, and I'll tag on to Greg. It's awesome you already got the kids tested, because that was going to be the first point I brought up, but you did that. Just a couple things that I just want to clarify, just more for the sake that there's new faces or new or newer people in the room or phoning in, but you feel like her adherence to the Hep C treatment, it sounds like she's not going to have a problem, but even you don't get that impression.
No, I don't have any concern about her compliance at all. The medications that we stopped for med failures for her bipolar disorder, we stopped as a group between myself, and when she was able to see psychiatry, she developed some side effects and felt like that they weren't really working. And she said, I think I'd just rather stop everything right now and focus on the hepatitis C.
Is she on any contraception? Do you know?
She's had a tubal.
Yeah, a tubal. Okay, gotcha. That was going to be my other question. And then more for clarification with everybody else also. So I know you started her Hep B vaccine series and then repeated it, but did you do surface antigen and core antibody too, just to make sure that she hadn't had like a prior exposure?
Yes, let me find that. So I initially screened her back in either late 2017 or early 2018, and I did the full workup then because I assumed that as long as she had it, she was going to be at least an F1. She's morbidly obese, and I figured if nothing else, she's got a little bit of NASH. So everything was fine. Everything was perfect, except she was still antibody negative. So that's when we repeated the hepatitis series.
Perfect. So, I mean, as far as treatment options for her, do you have an idea of which direction you'd want to go, or do you want us to give overall?
I assume she could use either Harvoni or Mavrite.
Yeah, so beautiful. Either one. So, I mean, the 4 treatment options for genotype 1A, in the absence of cirrhosis, in her instance, she could do Harvoni for 8 weeks. So just for everybody else on the line, if this is one pill, once daily option, and she could do 8 weeks because her viral load is less than 6 million, she doesn't have HIV, she's not African-American, she's non-cirrhotic, so she actually could do 8 weeks of Harvoni, which is probably going to be the least pill burden for her. Another option is the Mavrite for 8 weeks, but remember that one's also 3 tabs. You take once a day, but you have to take it with food. So it may not be as simplistic as the Harvoni. 2 other treatment options as well. Epclusa for 12, you could, but again, it's a longer treatment duration. And then Zepatier for 12 as well. But that would require, since she's a genotype 1 with subtype A, that would require doing the NS5A polymorphism testing prior, and then you also have to do a little bit more frequent lab monitoring of her liver enzymes. So yeah, either Harvoni or Mavrite. I don't see a problem with either of those getting covered by her insurance. And then you mentioned that you think she has some NASH, so I just wanted to make sure you did at least at some point some liver imaging on her too, like an ultrasound.
Okay, I have not done that, but I certainly can. I guess I kind of presumed that she'd had NASH, if for no other reason than just her morbid obesity. But
yeah, but awesome, beautiful.
Thanks.
Hey Jenna, this is John Gilfus. Good job. Hey, the only other thing I was going to mention is she's so early on that hopefully after treatment she'll be someone that you can literally never worry about having to do ultrasounds and stuff again. Again, this is for other people on the call, but if you're less than F2, you need to do. I'm sorry, less than F3, so F2 or less. No need to do long-term HCC screening. And then the only thing I was going to mention, we use our specialty pharmacy, so I feel in the luxury zone. I don't use that to counsel my patients on this, but remember that all the, if you do the Harvoni, a lot of patients are taking over-the-counter PPIs and stuff like that, the proton pump inhibitors. So remember the Harvoni does, while it doesn't have food restrictions per se, it does require an acidic environment. So you don't want antacid. But otherwise, hey, I thought it was a great job. How did you, out of curiosity, did you have any discomfort or anything discussing with her how the lack of transmission in a family dynamic, basically how transmission to children won't happen? Was she at all, you said she was worried about that.
Yeah, she was. I mean, I told her typical precautions. Like I said, obviously the kids shouldn't have access to your razors, and they don't use, there's no family members that use any kind of injection medications whatsoever. But, I told her things like, nasal sprays and stuff. I mean, the kids just stay away from that stuff, but there's not a huge significant risk. We talked about that. She was really reassured, but the kids had never been tested, and they're 7 and 9. So we tested them. I see them too. So I tested everybody.
Yeah, I just wanted to make sure that, because it's been a long time since we did the natural history talk, and that's always a big concern is, how can I avoid transmitting this to my children? And in general, we tell people to love on their kids, hug them, love them, kiss them, just don't share toothbrushes or razors or other implements like that. So good education piece. I'm glad you brought that up.
Nail clippers too.
Yeah.
We use them a lot in the whole family.
Good point. I don't think I would have thought of
I didn't hear her.
Nail clippers. Right, nail clippers.
Oh, that's really interesting. Okay. She's real, like I said, almost to the point of compulsive. She is really nervous. She also lives with her mother and stepdad, who I take care of also. And they just she's super, super careful about not wanting anybody to get sick from her.
I think she'll do great.
Yeah, I do too. And the last couple of patients that I have had with other behavioral health issues, I know that it's not necessarily a causative relationship, but it seems like when we make the Hep C better, their life just gets better. This huge black cloud goes away. And I am hoping that that's going to make it possible for us to revisit the bipolar treatment and have some success next time.
Great. That'll be wonderful. I wanted to point out real quick, Dr. Peters had sent a chat just making sure to get viral loads at 4 weeks into treatment and 12 weeks after completing treatment, just because Medicaid wants those numbers. All right, Jenna, are you good if I pull up your next one?
Yeah, let's do it. So the next one I captured, I started seeing him about 2.5 years ago. I actually treated him for the first time ever for an STI right before he went to jail for drug stuff. And I talked to him about hepatitis C then, and I said, do you know if you're positive? He said, well, last time I was locked up, they told me, yeah, but then they told me I cleared it. And I said, okay, so when you're done, I get kind of blunt with my patients. It's my personality. But I told him, when you're done messing around with your life and you want to get serious about being well, come back and we'll work on helping you be well. So he came back and he said, so I want to be tested. And so he's Hep C positive. And we knew that for about 9 or 12 months because he got lost to care, started using drugs again, got incarcerated a second time. And then showed back up recently, said I've been clean for about 6 weeks and I'm really done. I'm really, really done. So we've started this process again. He's enrolled in a methadone clinic, and there's a halfway house here that's faith-based that he's also participating in called the Lazarus House. So things seem to be looking up for him. And in the meantime, we'd completed all these labs. So I thought he would be a good one to present to. He's 32, normal BMI, a white male with Medicaid. His drugs of choice were methamphetamines and heroin. He used needles and shared needles, and also used straws when he snorted. He was not aware during part of our education piece that they can share communicable diseases like Hep C and HIV through straw use. So that was kind of eye-opening for him. And he also has some tattoos from prison. Like I said, he got conflicting results of hepatitis C status when he was incarcerated. Like, again, he said, well, they told me I had it, but then they told me it went away, that I cleared it, so I don't think I could get it. And I said, well, let's check again and let's see if they were right. He does not endorse any symptoms of depression. His substance use history, he's currently still drinks alcohol, but couldn't recall the last time he drank. And opiates and stimulants like meth, snorted last meth use was mid-October. Last IV drug use was heroin in June. Still uses cigarettes and snuff. His labs were fairly unimpressive, except he had some elevation in his transaminases. So I reordered, I need to double check in his chart, because when I posted the case, there were still some hepatitis labs pending. But like I said, he still has some elevated transaminases, and he's an F1, F2 fibrosis score. I'm not certain if the elevated transaminases are new, because I didn't have any baseline labs on him. But I'm sure that could still just be from the hepatitis C.
Great, excellent. Thank you so much, Jenna.
Sorry, I paused for a second. I was double checking. His hepatitis B immunity was negative when I screened him in April, and so we restarted the series, and then he got lost to care. So I'm finishing his series currently, but his Hep B core antibody was negative then. I don't know why I didn't include that, but I didn't. I don't have a genotype on him either. I ordered it, and we actually just talked to him this morning. He's having some car difficulties, but plans to do it this week.
No worries. So same question for everybody. Questions, comments?
I would be real interested to hear what John and everybody would do with this guy. This is a guy that I might actually wait to treat. He may actually even have acute hepatitis C just with his elevated transaminitis. He's got at least 2 or 3 different reasons to have transaminitis, but I wonder if maybe not kind of slow playing his treatment, waiting 6 months, rechecking everything, see if he clears it himself, and also give him a chance to kind of prove his commitment to sobriety makes the most sense in his case. Plus it gives you time to do his hepatitis, walk him through all that stuff, do his hepatitis B series and his A series, all those sorts of things. He ought to have that stuff done anyway. I would also consider giving him Narcan. Might be a good thing to prescribe as well.
So he's actually an individual that I referred to our addiction medicine group, and then when they reached out to him, so we are fortunate enough to have a case coordinator who, and Dr. Peters knows this is for everybody else's benefit. We have a case coordinator who will reach out to patients who are struggling with addiction, alcohol use, and dependence, like this guy in particular, to help facilitate getting enrolled in an intensive outpatient program or enrolling in something inpatient, or just making sure that they're getting routine follow-up to care. And between the day that I saw him, which was a Tuesday, and Thursday when our care coordinator got in contact with him, he'd already enrolled in another methadone clinic in town, which I think for just transportation purposes was easier for him based on where his job is and where he's going to be staying with the Lazarus House versus the Vivitrol clinic that we have in Weston. I'm assuming that the methadone clinic has gotten him Narcan, but I'll verify that the next time I see him.
I always find it prudent just to assume they haven't and just do it again anyway, because it's just, you know, having an extra Narcan prescription is just.
And you mean like a Narcan pen?
The nasals, like the nasal spray stuff. And I counsel people about that a lot, actually, kind of routinely. And I write prescriptions for that for people that don't even carry the diagnosis of substance use disorder, and talk with them about this being something that somebody can use on you, but also something that you can use on other people. I've actually had more patients end up doing that. I've had 4 or 5 different patients save lives of other people that were around them. And I don't think I've ever had a patient whose life was saved by a Narcan prescription I wrote, at least not that I know of, for what it's worth.
Thank you, Dr. Peters. Yeah, people agree with you. All right.
Are there sobriety restrictions in West Virginia? 3 months.
Yeah.
That's what I thought.
The only other thing I would add is that sometimes if he's been incarcerated multiple times, it's likely that he might get incarcerated again. And that happened to me with the lapse in getting the medication on time. So depending on how long he's been out, you know, compliance definitely becomes an issue outside of his hands if he goes back to jail.
Okay, yeah. So the next time I see him, I'll address if he's got any pending legal stuff he might end up going back to jail for. That's a really good point I hadn't considered.
Because the insurance won't disperse the medicine if they're incarcerated.
Yeah.
Yeah, so that's a good idea.
Great. Thank you so much, Dr. Biggers.
He's a neat social case too. He told his sister I was going to treat him for Hep C, and his sister came in because she's Hep C positive too. And he was living with his brother-in-law who was Hep C antibody positive, but his PCR is negative. So it's very likely that they all used together. He's not around that same group of people anymore, but yeah, I guess he had some communication with his sister about it. So that was kind of neat too.
This is Kaylee, Jenna. This is awesome. This is a good case. A couple things just to kind of just pointing out, looking at his lab work and kind of his exposure history. I'm wondering if there's some scenarios. Sure, he could have gotten infected with Hep C and then cleared it and then got reinfected again. Who knows how many times? But I'm wondering, with his labs being drawn in October and he was still using meth then too, I bet that is playing into his transaminitis as well. And I would definitely counsel him on that too, is how hepatotoxic that substance in itself is as well. But I bet if you continue to follow those, that even independent of the Hep C getting treated, it will kind of start to trend down. Because that's still pretty high with hepatitis C by itself. And then two, just kind of, as you're working with him, just, remind him, I kind of let my patients dictate when they're going to get treated too. I mean, even if he's at his sobriety meeting that 3-month criteria that Medicaid requires, I let him know you're probably only going to get 1 shot at doing this. So, if you're ready to take that at this time, then we can do it together. If you want to kind of work on your sobriety for a little bit longer, that's fine too. But I let them kind of do some shared decision making with that also, since this is their life long term. But I just keep bringing that conversation up with him. And then I had another point to make, but now I lost my train of thought. Oh, it actually wasn't related to him. When you brought up that his brother-in-law or whatever had a positive antibody but a negative viral load, just remember, because we've gotten into some difficulties with patients that kind of come in and it looks like they cleared, and then we say, okay, you're good to go, and kind of release them out into the world. And then really make sure you have 2 negative RNA tests documented 6 months apart from like their last exposure before you can say, hey, you're cleared. Because I actually saw a guy today that had that happen. Had seen somebody, they repeated his RNA, it was negative, and then now he's back into care because it's positive, but he was told he'd cleared it a few years ago. And I don't think that was the case.
That's interesting.
Yeah, so just really make sure you have 2 RNAs documented that are negative.
So I'm sure the brother-in-law is really forthcoming with all of his history, because this individual, the one I presented, is very upfront. He's like my favorite kind of patient, the no shame, like I'm just going to lay it all out, and super forthcoming. So some of the stuff that he revealed to me in discussion makes me think, yeah, the brother-in-law is probably still using. Now the brother-in-law is in his mid-60s, has 2 bad heart valves, and is B core positive. And he's a really neat case, but he keeps falling out of care. I keep losing track of him. So he's a case that's been presented once or twice to the heart group because they can't get him healthy enough for a new valve.
Wow.
So yeah, he's kind of neat, but that's a good point to make though about testing him more than once for the Hep C. I'll be sure to do that.
And go ahead.
No,
you
you're
want to
good.
talk about the viral one with Medicaid?
Go ahead.
Sorry. And then just because these Medicaid, West Virginia Medicaid kind of criteria has changed recently, one of the other ones that they've changed since they removed that fibrosis restriction was having 2 positive RNAs 6 months apart to differentiate technically between acute and chronic. So in his case, even if he may have tested positive when he was incarcerated and then told he cleared, and then when you tested him, he's positive now, just make sure you have like that trend of persistent viremia before you actually treat him. Because if you have a viral load from April and then he wants to get treated, you'll still need to repeat that one again just to make sure.
For good reason, like Dr. Peter said, maybe he just has acute Hep C.
Absolutely, yeah. But yeah, I would agree with following him for a while and just seeing what happens.
Okay.
Jenna.
Yeah.
Alice and I, hi, this is Kelly. We were from Pittsburgh, but Alice and I were also concerned, again, with what Dr. Peter said about the acute Hep C, but we were also a little bit concerned about his alcohol use and perhaps abuse. As we were looking at his, his drinks, he actually drinks an awful lot. And perhaps when you were getting his next set of labs, you can look at something like a GGTP or something to see if he really was drinking in excess, because we were concerned about the transaminase levels too, and maybe look at the cholestatic enzymes also, see if that alcohol was playing a part in that high enzyme count.
Looking back in his lab history, the first positive Hep C, I ordered it as a reflex to PCR, and I don't see the PCR in here, but it was reactive in April, and I have another positive in October. So I think we're demonstrating some chronicity, but still definitely a good point.
Thank you.
Okay, Jenna, this is John Gilford said. And Greg, to get to your question, I would slow play it exactly like you mentioned. I love how you put it, from both social reasons, even medical reasons as well. Jonathan's point's well taken as well. I think socially you want to slow play him, and medically he may be acute, and let's see what happens from a clearance standpoint. I wanted to leave you guys with just a reminder of the risk factor, I should say the host factors that can lead to viral clearance. So we don't know if this guy really cleared before, but at least it gives a history of it, have an antibody positivity. And if a patient actually says their viral count was negative, it probably was. Again, like Kaylee mentions, that doesn't mean you couldn't call it quits at that point. So I always encourage them that, yes, your antibody will be positive for life, but it's not protective. It sounds like he's a smart guy. You could explain that too. And then going through the host factors, I'm just going to read them. So younger age. So obviously having Hep C at a younger age is a risk, or I should say, risk factor is the wrong word, but is a host factor that can lead to clearance. Female gender, being of non-African descent, having a symptomatic or highly symptomatic acute infection. And not that he's jaundiced, but his transaminases are darn impressive. And so it almost is a good thing in my mind. having HIV co-infection is the opposite. So if you HIV negative would be more likely to clear. And then the last is an interesting holdover from the interferon days. So there are people who have certain polymorphisms of part of their own immune system. The interleukin gene is one that we used to measure these back in the interferon days. We would have a test you could do that would be prognostic of whether a person might respond to interferon. Even though we don't use interferon anymore, that polymorphism is still part of our genome, and some people out there are those lucky polymorphisms that are more likely to respond to their own endogenous antiviral, their own own interferon. So people who clear it are technically genetically blessed to potentially do it again, but again, how?
28B. Yep.
Yeah, IL-28B, and you don't want to encourage somebody to dodge bullets twice, but sometimes they can. And that's the only other point. Slow play, 100% agree for all those reasons, both medically and social.
Can I add one thing?
Please.
So this is Jane. I'm from hepatology. I'm advanced practice. Because his numbers are so high, you know, I mean, it might be drug induced. It could have been that he was using whatever and it's an acute infection, whatever. But because they're so high, I would do an autoimmune panel on him just to rule out autoimmune hepatitis. So an ANA and then an IgG at the very least, just to rule that out, because if he has underlying autoimmune hepatitis, then you have another whole situation you have to deal with.
ASMA.
And an ASMA, yeah, sure.
Great. Thank you, everybody. And thank you again, Jenna, for both of those cases. That was great. That was great discussion. I really appreciate it. We are right at the end of the session, but if you guys have any questions or anything, we can definitely follow up on those via email. And I want to remind everybody that our next session actually falls on Thanksgiving, so obviously we will not be meeting. So we will only, I hate it, but we will only have one session in December as well. So that's going to be December 12th. If we have enough cases, we will just use that whole session for cases. So just let me know if you want to get on that agenda soon, all right?
Okay. Thank you so much.
Yes, thank you.
Thank you.
See you all later.
Bye.
Thank you, Ray.